Hello, everyone. Uh, I bring you warm wishes from the holy city of Varanasi. At the outset, I'd like to really thank Professor Sandeep Verma for letting me speak on this forum. And today I'll speak on a very neglected topic, that is women with HIV. And I'll give you a short overview of the social demographics, the clinical profile, as well as the treatment outcomes in our women living with HIV in the tertiary care center. Among the 38.6 million adults living with HIV, women account for around 20.8 million, that is almost 54%. And they account for 42% of deaths due to HIV and 44% of all new HIV infection. In India, there are estimated 2.4 million PLHIV, and women are about 45% of them. Women living with HIV face certain unique challenges, and the first and foremost is social stigma surrounding HIV infection. Many of these women are economically dependent on their spouses or partners, which can hinder their treatment access. Gender-based violence is also common among them, which increases their vulnerability not only to HIV infection but other STDs too. And there are certain cultural attitudes, especially in Indian women, where they neglect their own health, and women's health is also neglected by their family. To top it all, male to female transmission of HIV is 1.9 times more effective. And all these factors make women very, very vulnerable. It has also been observed that in India, more than 90% of the new infections among female occur mostly within marriage. And a significantly more the women living with HIV have migrant husbands. Especially in this part of the country, that is eastern Uttar Pradesh, where I come from, there's a whole lot of male migration to big metropolitan cities for economic reasons. Now, these males leave their women or their spouses back in their villages, and they get this infection, HIV infection, in the metropolitan cities, and they come back home and give it to their wives. So this is a problem very, very specific to this region of the world. So women with HIV bear a triple jeopardy impact of HIV/AIDS. That is, they are infected themselves and they may be ill, but still they are mothers of children who might or might not be HIV positive, and they have to take care of them too. And they are also caregivers of their partners who are most likely HIV positive. A word about our National AIDS Control Program. It was launched in 1992, and the first ART centers were started in April 2004 in 6 high prevalence states. And as of 2024, we have around 772 ART centers and 1,261 link ART centers, which provide free ART to more than 1.68 million PLHIV in the country. We also do free viral load testing for our ART center in Banaras University was established in 2005, and it was the first as well as the largest ART center in the state of Uttar Pradesh. It was upgraded to the Center of Excellence for HIV Care in 2010 with the mandate of training, mentoring, as well as doing HIV research. And since its inception in 2005, we have registered a total of around 20,000 PLHIV, and out of them, 7,334 are women. And today I'm going to talk about these women who have ever registered in our center. When we compare the baseline profile of our male and female HIV patients at the time of their registration, we observe that the females are being registered at a younger age as compared to the male counterpart. They are more likely to be uneducated. They report sexual transmission as the most common mode of transmission, and followed by blood transfusion. And they are much, much less likely to be employed than their male counterparts. And naturally, they have a lesser monthly income, and a big proportion of them are either widowed or separated, and almost 50% of them have a spouse who is HIV reactive. So if I can summarize this, the women who are being registered in our center They are actually younger than the male counterparts. They are more likely to be uneducated, unemployed, with less income, and with less family support because many of them are either widowed or separated. But they have to also take care of their spouses who are quite commonly reactive. Now, this makes these women very, very financially as well as socially vulnerable. But everything is not bad for these women. So if you just look into the substance use, we find that our women has considerably less tobacco chewing, smoking, as well as alcohol intake as compared to their male counterparts. They are also more likely to have a better CD4 count, a better WHO clinical staging, and a better functional status. Most of them are working at the time of registration. Now, that suggests a very good immunity, and that is reflected on the opportunistic infections too, where the males are significantly, males have significantly high risk of having opportunistic infection, which is seen with tuberculosis, cryptococcal meningitis, as well as pneumocystis pneumonia, the three most common opportunistic infection in our setup. Now, why is this? The most common explanation is most of the women who are diagnosed with HIV are diagnosed because their male counterparts, their spouses, have come to our ART center to seek medical help, and that is when the females are tested and they are found to be HIV positive, and that is why the immunological profile is much better than their spouses or their male counterparts. When we compare the adverse effect, there is no difference, though although many studies have shown that women have more adverse effects than their males, but we did not find any such difference in our cohort. And when we compared non-communicable diseases like hypertension, diabetes, cancer, and chronic kidney disease, there was no difference between males and females, but males were significantly more likely to have syphilis and hepatitis B. Besides comparing our baseline demographic data, we also did a time trend analysis to see whether the data varied from 2005 to 2025. And here is what we found that the female registration varied from 30.6 in 2005 to 10 and to 41.4%. But the mean age of the females did not change much, and it remains significantly lesser than those of males. The percentage of females with CD4 count less than 200, that means percentage of females with advanced disease, remained almost similar and significantly lesser than the males throughout the 20 years period. But there was a significant increase in the baseline CD4 count, both for males as well as females. And you will see a small peak here between 2015 and 2020. And this peak is due to the fact that in 2017, the government of India adopted treat all policy, where we had to start all PLHIV on ART, irrespective of their CD4 counts. Before this period, ART was only started in those with either CD4 count less than 200, which was followed by CD4 count less than 250, followed by a period where we gave ART only to those with a CD4 count less than 350. And the treat all policy, which came in 2017, we actually called back all our registered patients who were registered but not initiated on ART because of their good CD4 count, and that may have led to this peak during this time period. And similarly, if you look at the percentage of tuberculosis, there is a downtrend in the percentage of tuberculosis among our PLHIV in the 20-year time period, but the male-female difference remains the same. So males are much more higher risk of getting tuberculosis at the time of registration as compared to the females. Besides comparing our baseline data, that is data at the time of registration, we also compare the data between during their follow-up, where we compare the current BMI, CD4 count, clinical stage, as well as functional status. And what we observed that females had more likely to have a CD4 count more than 200 at follow-up, a better clinical stage as well as a better functional status. This was very expected because females already started with a better CD4 count stage as well as functional status. But what was really concerning was that females were more likely to be overweight and then their male counterpart after ART, and you might be confused about the BMI cutoffs. These BMI cutoffs are for Indian uh, people. So we have a lower cutoffs than the Western world. So that was really concerning because Government of India brought dolutegravir, which is an INSTI, that is integrase transfer inhibitor based therapy, in 2020. And many studies have shown that INSTIs can cause a lot of weight gain. And this weight gain is more in females as compared to the males. And though insignificant, but this percentage of weight gain it led to increase in diabetes. Well, India is already a diabetes capital, and this is something we really need to observe closely whether our females are more likely to gain weight and become either hypertensive or diabetes. On comparing the treatment outcomes between our male and female HIV patients, we found that the virological suppression was similar in both the groups, and females were more likely to be in first line as compared to males. And there was a significant difference in mortality between the two groups, where male were at a much higher risk of mortality than the females. And the reason could be that males were much more immunocompromised at the start of therapy than the females. But studies in early in the epidemic has shown that females were more likely to die and have higher mortality as compared to men. And this differences could be due to the decreased access to quality care and treatment. But post highly active ART availability as well as provision of free ART, this difference has actually smoothened out, and now the studies have shown that females have a better survival than males, similar to the findings in our study. If you look into the mortality, percentage of mortality over the years, there is a significant fall in mortality, both among males as well as females. But the difference of mortality between males and females remains the same, with males being at a much higher risk of mortality than the females throughout the 20 years of our ART center. Before I end my presentation, I would like to say a few words and share our experience of cervical cancer screening in our ART center. Now, cervical cancer is the second most common cancer among women in India, and women living with HIV have a six-fold increased risk of cervical cancer as compared to women without HIV. Not only are these women at increased risk of acquiring HPV infection, but they are more at risk of rapid progression of these infection to precancerous lesions and subsequently cervical cancer. So, primary screening is highly recommended in this cohort of patients. And in India, the primary screening is usually done by pap smear or visual inspection with acetic acid, that is called VIA. Between 2010 and 12, we did a study to detect the prevalence of HPV infection and cervical abnormalities among our women living with HIV. And we enrolled around 216 women using pap smear. And we also did a HPV detection using consensus primers. And what we found was HPV positivity to be around 26.85%. And most of these HPV were high risk HPV. The risk factor for acquiring HPV in these women was age less than 35 years, illiteracy, rural residence, and CD4 less than 350. Now, around 25% of these women also had abnormal cytology, and the risk factor for abnormal cytology in these patients was WHO clinical stage of 3 and 4 and CD4 less than 350. After we did this study, we actually wanted to bring it into our routine practice, but we were not successful because for pap smear, we had to send all these patients to the gynae OPD. And the normal gynae OPD has around 300 to 350 patients, so our patient had a long waiting time. Moreover, none of these patients were symptomatic, so they did not want to go to gynae and get a test done. Um, and that is why when the recommendation of WHO changed in 2021 and they made HPV DNA detection as a primary mode of preferred primary mode of cervical cancer screening for HIV patients to be done and started at the age of 25 and then done regularly every 3 to 5 years, we were quite encouraged. And WHO also promoted HPV self-sampling and saying that it was equivalent to provider corrected samples. And because the acceptability of self-sampling is very high, we wanted to go ahead with this study. And recently, between 4th April 2025 to 16th May, we did this study on detection of HPV through self-sampling. And we approached around 675 women, and out of them, 599 gave their samples. The 76 women who did not give their samples, the main reason for denial were hysterectomy or menses, and five of them had pregnancy. Only seven women had fear of getting tested. Now we perform this test using the Abbott real-time machine. And this machine is also used for our viral load testing. So we didn't have to go anywhere. At this time point, we have tested only 516 samples, and out of which 147 came out to be positive for HPV. And that is the prevalence is around 28%, and which is similar to what we found in our previous study. Now, HPV type 16 genotype was the most common genotype which was positive in our patients, and many of our patients had more than one HPV genotype positivity and mixed infections. So this study made us feel very encouraged, and this is maybe the way to go in future. And this is how we can include all our women for cervical cancer screening, as self-testing is very, very acceptable to our women living with HIV. So to conclude, women living with HIV in our center are socioeconomically vulnerable. Why? Because they are presenting at a younger age. They have a higher likelihood of being uneducated, unemployed, being separated or widowed, or and having HIV positive spouses to take care of. So we need to do something to help these poor women out, maybe economically help them and link them up with a lot of welfare programs which are already available in the government. But the good things about the women living with HIV in our cohort is they have a better WHO clinical stage, better higher CD4 counts, lower rates of opportunistic infection and mortality at the time of registration. The treatment outcomes are almost similar in between our males and females, and but our women are more prone to post-treatment weight gain, and they may be overweight, and that needs to be followed up closely in future. And HPV self-collection for cervical cancer screening is very feasible for our women, and there's a huge potential for integration with routine HIV care. So with this, I conclude my talk and thank you very much for your patient hearing.